Thank you very much for inviting me. It's just going to talk for 10 minutes about our experience of cardiac CT. We've had wide area detector CT for almost 10 years now, so I'm just going to talk about what advantages we've found with it in a large general hospital. So conventional detector CT coverage is quite narrow. You can only cover about 4 centimetres of the heart, and that includes pretty much all systems apart from the wide area detector ones. So that means that you have to scan the heart over multiple beats, essentially. And a lot can go wrong with multiple beats. The equivalent one wide area detector scans the whole heart in 16 centimetres, which is more than enough to scan pretty much everyone's heart. So this is how it works. It's quite simple to explain. Basically, the ECG goes away. It's ECG gated. The scanner just fires it end diastole, then switches off again. So 70 to 80% of one beat, and it acquires the whole data set in a single beat, which is very simple. And that simplicity actually opens up a whole load of possibilities, which we didn't have before. So the key bit as a reporting radiologist is the fact that all of the data is acquired at the same time, which is an enormous advantage. So one of the biggest, I went to a conference just now when we had a load of test images up and we were trying to teach cardiologists and radiologists how to do CT, and so many of the cases were difficult because they were on conventional systems and there was a lot of step artifact. You don't get any step artifact on a wide area detector, so the whole data is all at one point in time, and you also can see things like this. This is a communication between the aorta and the pulmonary artery, and you can see a jet of contrast coming across a PDA. And you can see this really easily because it's all acquired at one point in time. And this is an absolutely typical patient. This is not the best patient we've ever had. This is not the thinnest patient we've ever had. This is just a typical patient. Typical BMI in the UK, because we're all quite fat, is about 26. And this is a typical patient, and they get 0.6 millisieverts now. So you get beautiful images of the coronary arteries because the single beat acquisition, together with some other things that I'm going to tell you about, is incredibly dose efficient. So it's not a big deal now doing the coronary arteries. It's not a high dose test anymore. It's 0.6 millisieverts, and you get beautiful images of the coronary arteries. That's the LAD. So what about irregular heart rates? Now, the biggest reason why I can never go back to narrow detector CT is that it doesn't cope well with irregular heart rates. And we don't even worry about irregular heart rates anymore, and I'll explain why. So if you've got the conventional narrow detector CT and you're acquiring the heart in multiple beats with step and shoot, so you're doing the top of the heart, then move, middle of the heart, then move, and then bottom of the heart, there's a lot that can go wrong, and the heart rate can change. So you've got a fixed offset, but basically the scanner can fire at a different phase in the cardiac cycle as it goes down through the heart. Not only does that cause step artifacts, but actually the coronary arteries in some of those steps can be completely blurred because it's fired at the wrong time of the cardiac cycle. And this is images that we used to get. This is not a diagnostic image. You can see it's all a lot terrible misregistration. And people say, well, that's fine, you just use retrospective gating. That does not solve the problem. This is retrospectively gated study in patient with atrial fibrillation, and it still looks terrible because everything's acquired at a different point in time. And even when you have someone with a fairly regular heart rate, just one ectopic beat, you get a big gap in the data, and then you get a big gap in your coronary arteries, and that can ruin your day, and it can ruin the day for the patient because they have to come back again or they have to have another test. So how does the Quillian-1 wide area detector cope with arrhythmias? Well, this slide looks complicated, but the clever stuff is all done for you, luckily. Basically, the scanner continuously monitors the heart rate, and it continuously adjusts where it's going to fire its radiation pulse. The original wide area detector way back when we started in 2007, it decided in advance that it was going to fire a certain number of milliseconds after the R wave, and that was what it was going to do. It didn't matter whether the heart rate changed, so it sometimes fired in the wrong place. Now, there's a very sophisticated system now that continuously adjusts where the pulse of radiation is going to fire based on changes of heart rate. So it always fires at the right time, and it's incredibly robust. And if you get an unexpected extra beat in, the scanner will abort, it'll wait, and then it'll fire on the next heartbeat. because it only needs one heartbeat, so it can wait 1 beat, it can wait 2 beats, it can wait whatever. And this is the biggest reason that it's incredibly robust, and it just always works. It works in any heart rate, it works in atrial fibrillation. So it works in irregular heart rates, and that's incredibly reliable. But what about high heart rates? Well, surprisingly, in some ways, it actually has a huge advantage in high heart rates as well, because you would think that it's just related to the rotation time, but it is much more than that. Even a wide area detector scanner with the same rotation as a narrow area detector scanner copes much better with high heart rates, and that's because when you breathe in, your heart rate instantaneously can drop by about 10 beats a minute. Now, it only does that for a couple of heartbeats, but the Aquilium 1 just fires with its one heartbeat, and it catches that trough in heart rate. So someone's going along at about 80 beats a minute, even if I've given them a load of beta blockers, they breathe in, their heart rate drops to 65, it fires, and you get a perfect image. And that effect is incredibly useful, but you can only get that if you're requiring the whole heart data in 1 beat. So that's an advantage, but if the heart rate's still really high, even when they hold their breath, you basically just need to widen the radiation pulse. And you acquire end systolic and end diastolic data as well. That sounds like that would be very dose inefficient because you'd be acquiring data throughout most of the cycle. But because with retrospective gating, you have a lot of oversampling going on. It has to sample the heart at least 3 times for every data point. You don't have to do that with a wide area detector system. It doesn't have that inherent oversampling. So you have a bit more radiation, but the actually RR interval is shorter. So the actual amount of extra radiation is incredibly small. So even at high heart rates with a slightly wider radiation pulse, we're still talking about doses of about 1 millisievert, which is still about 1/6 of a cardiac catheter. And it's also much more robust as well because of the fact that it's still 1 beat. And these are the images you get at high heart rates, 80 beats a minute. If you used a normal end diastolic reconstruction, you would get a blurred coronary arteries there. And if you use the data at the beginning of the cardiac cycle, the end systolic data, you get still coronary arteries. And it basically massively increases the robustness. And it's still at very, very low radiation dose. And this is the proof of the pudding, putting that all together. This is a patient that we just couldn't have scanned at all before. This is atrial fibrillation going at 101 beats a minute. And this is end systolic recons, and you get perfect images of the coronary arteries and at about 1 millisievert. And also, you get free functional images. This is ejection fraction 7%. You could ask yourself why the patient was having a CT, because evidently the problem was the fact that the heart was not beating, not the coronary arteries. So why the radiation dose is so low? Well, there's no slice overlap. It's much more dose efficient. You can always use prospective gating. You never have to go retrospective. But there's another thing, that the detector technology is massively improved. And this is the biggest thing that's changed for us, is the Purevision detector, which has got a different material, which I don't claim to understand. And it's basically just much, much more dose efficient. It makes much better use of the photons coming through. And this is, our data, which shows but basically we had a study where the only thing changed was the detector. Everything else kept the same. And we got a 44% dose reduction for the same image quality. So that is, you're having your free lunch here. This is a free lunch. And this is the sort of data you get now. 26-year-old woman, normal size, 0.1 millisievert now. So if they're really young, we can turn the dose down to a chest X-ray dose now. And this is planning for atrial fibrillation. For the electrophysiologist, we can do doses of 0.1 millisieverts. I never thought I would see a DLP of 7 on a CT scanner for an acquisition, but it is extraordinary how things have moved. And these are the kind of, how do we compare with the kind of national figures? This is the dose data for the British Society of Cardiac Imaging, which is all cardiac CT scanners across the UK, and we're green, which is we're down to about a millisievert for all comers. So the radiation dose is just not an issue anymore. So in summary, arrhythmia has traditionally been the real fear of cardiac CT and the biggest reason you couldn't do it. That's now not a problem anymore because we can scan pretty much everyone. Fast or irregular heart rates is just fine because of the single detector, single beat technology. Radiation dose, I have to say, I just don't think is an issue anymore. I don't think we need to worry about the radiation dose anymore. We are not giving anyone cancer, I would argue. The Challenge of the future, spatial resolution will improve even further with new reconstruction technology, particularly with the model-based history of reconstruction, and that's one of the major developments which we're being involved with. And to be honest, it's a robust test, so the only problem we now have is how to cope with all the patients. And thank you for your time.